So very good morning to everyone. I think first of all, hearty congratulations to the department for the Foundation Day program and coming back to LGPGI in any form, on any pretext, I think is more of a nostalgic moment rather than an academic exercise. And it's very nice to see everybody. Sir is there. I just saw Sir Gaurav and Anit walking in. I think it's more of a casual chit chat which we want to do today rather than an actual talk. But then I think so. What I wanted to discuss was something regarding what Sir, Madam, Dr. Jain, Dr. Phadke, they taught us when we were in our residency time. And we are all doing cases here also. I know we are doing a lot of cases of portal hypertension. But then I was told that there will be a lot of resident doctors and our juniors will be there in this hall. So I just wanted to share with you what I have learned over time about whenever I get a case of portal hypertension. So how should we start evaluating it? I think procedure we all know. You may have seen the procedures of endovenous sclerotherapy as well as doing a shunt creation. But then I think it's very important for us to understand that what goes behind the scenes. What are the pathophysiological considerations and what all we should look for while we are beginning to evaluate a case and planning it for interventional radiology procedure. Classically, we have been told that it's just the altered portal physiology, the altered portal blood flow that goes in causing the disease process in portal hypertension. But now, with the increasing body of evidence, there are many more stakeholders which have been brought into the picture. That is the systemic inflammation, the mitochondrial dysfunction, the metabolic alterations. Now, these things also have to be evaluated and simultaneously taken care of, so that even if we end up creating a successful shunt, we don't end up creating a complication. But then all said and done, if we correct the basic pathology, that is the altered portal flow, the other things, they tend to fall in line. But then we have to understand that what extra we have to do and how we have to evaluate it. The endpoint or the aim of treatment is obviously to offer patient a transplant-free and a disease-free survival. And that is obviously done by controlling the third space fluid accumulation and the bleeding, which in turn can either be done by endovenous route sclerotherapy or a shunt creation, or that is the endovascular route, that is the interventional radiology procedures, or a surgical procedure, or a endoscopic procedure. So usually the patient would come to the gastroenterologist. They would try to do it in a conservative manner using the medical treatment as well as the endoscopic route. And when that fails, then there is an option of going in for surgery or for IR procedure. And as we all know that nowadays, IR procedures are sort of competing with the endoscopic procedures for becoming the first treatment of choice for portal hypertension. And this is what I was saying, that initially the buck used to stop over here only, that there was cirrhosis, there was altered portal flow, there was liver cell injury. And we used to think that if we correct this, this is the sole cause of portal hypertension related disease, the clinical disease. And if we correct this, the patient will be relieved. But then there are many other things which started to pop up. And then the research showed that after portal hypertension develops and the liver cell injury develops, we have certain proteins, the damage associated and the bacterial translocation associated proteins that were secreted in the body, in the serum. And these led to release of the pro-inflammatory molecules, that is the reactive nitrogenous and oxygenous species. And these species led to an overall systemic arteriolar dilatation, capillary dilatation, and cardiovascular dysfunction. So initially, we used to think that the thing stops over here only, but then there's a long chain of events which ends up causing the clinical disease. So we can't, because there are so many more things that are occurring, therefore we can't focus our treatment to this place only, and we have to look at the disease process in toto so that we give actual relief to the patient rather than just performing a procedure. So we know that all these complications are, whether it is ascites, whether it is hematemesis or cardiovascular dysfunction, renal failure, they are because secondary to all these processes put together. But the good news is that about 40% of the pathophysiology is reversible. So even in advanced cases, you would have 40% of the things that can be brought back to normal, that can be halted. And so once, and the most of the literature that I'll be talking about is targeted or has been researched on shunt creation, because endovenous or endovascular sclerotherapy is just for stopping the bleeding, mostly for stopping the bleeding, though it helps for encephalopathy also. But most of this is for shunt creation, and we act by increasing the flow towards the heart. So the preload to the heart will increase. This will increase the circulating volume into the body, the cardiac output and the cardiac index. And therefore, it will reset the renal system, the renin-angiotensin system. But then simultaneous to this, there are certain other end organs that have by the time all these things they present as a clinical disease, they would have started playing their role in trying to decompensate, in trying to reverse the process, that is the heart, the brain, the kidney, and the lung. And these are the organs, therefore, which we should evaluate before starting a corrective measure or a corrective procedure for portal hypertension. Otherwise, once we start the corrective process, these organs will try to reverse themselves, leading to complications. So that is in short what we should do. And most of the indications currently are aimed towards these 40% reversible causes only. So we are trying to either halt these or we are trying to reverse these. So once we start the evaluation in our practice, what we do is first try to map the drainage route. Now that can be done by various imaging modalities are there, very good quality CT angiography images you can get where you can map the route and the accessibility. So first, obviously, the endoscopist would prefer to perform it in an endoscopic manner, the sclerotherapy, but if it is not there, then you can do it from the endovenous approach also. You must be seeing cases in your institution also. And then the shunt creation, I think that is the procedure which has to be done. And the second thing is that the gold standard even today for evaluating the portal pressure is the hepatic venous pressure gradient. Although other things are also there, but HVPG monitoring should be done. And in advanced centers, in high volume centers, all treatment, even the endoscopic treatment, the medical management should ideally be based on HVPG measurement. Although we'll see that there are certain non-invasive techniques also which are coming. And the mapping of the drainage route in turn decides what should be the urgency of intervention and what is the choice of treatment. Because by this, we will get an idea that what are the collaterals, where are they located, how can we reach, and what approaches can we use to reach those collaterals. And just for an example, if we are having a coronary vein which is dilated, then that's, if it's significantly dilated, that's an indication for urgent management. If the anterior branch is involved, then obviously the esophageal varices will be more prominent and an endoscopist would get the preference for managing initially. But if the posterior branch leading to paraesophageal varices, which are quite nasty for bleeding, so in those cases, you'll have to perform an IR procedure. And in esophageal varices also, if they are not responding to non-selective beta blocker therapy combined with endoscopic sclerotherapy, in those cases also, you can go in for endovenous sclerotherapy. The gastric varices also, most of the times you would hear the endoscopist saying that, well, we can manage it very nicely by endoscopic sclerotherapy. But then many times don't hesitate from offering them endovenous sclerotherapy, because these sometimes they are not able to control, and then finally the patients end up with massive bleeding. And the other varices like the paraumbilical, the stromal and omental, these also have to be sort of managed by a combined endoscopic and endovenous approach, because they are notorious for causing refractory hepatic encephalopathy and ascites. HVPG obviously is as on now, this is the gold standard. All calibrations of various non-invasive techniques and various other histopathology has been done in relation to the HVPG, because this is the most robust way of giving an idea of the photosystemic gradient, and it correlates well with the clinical stage as well as with the long-term mortality. And even if the patient is on conservative therapy, this is the best way of saying whether he's a responder to conservative management or not. So for predicting the survival and for saying what is the outcome in terms of ascites, in terms of a spontaneous bacterial peritonitis and risk of bleeding, It is an accurate technique for assessing the photosystemic gradient and for predicting advanced fibrosis. And also, if we can show that on treatment, we are maintaining the HVPG below 10 millimeters, then the patient will have very less chances of developing cirrhosis in long term. And it can also help us decide that what would be the chances for prognosticating the patient, for explaining the patient that what would be the chances of having a prolonged hospital stay, what will be the chances of having a first variceal bleed, and in patients of alcoholic cirrhosis, what will be the chances of, what will be the short-term prognosis for the patient. If a patient of alcoholic cirrhosis walks into your ER and you are able to correct the pressure photosystemic gradient within the first 48 hours to show that he's a responder, then that's a very good green flag for the patient in long term. And at some centers, this has been used, the HVPG has been used for monitoring the non-selective beta blocker therapy also. Actually, in our center also, we have started a project in which we are trying to calibrate the timing for which and when should we call it a non-responder if the patient is on non-selective beta blocker by using HVPG. And it has been again shown that the likelihood of rebleeding in unintervened patients can be monitored by the pressure HVPG measurement. And the therapy itself, that is the NSBB therapy with EBL, that is endoscopic band ligation, can be monitored by HVPG measurements. And that's just one study. There are many studies are there. This is one good study in which they tried to, it's a systematic review of a large number of studies and large number of patients, where they showed that an HVPG reduction from the baseline as well as the absolute value can be put together to predict the pooled odds ratio as well as mortality. So that pooled odds ratio is for the variceal bleeding and the long-term mortality. So you can use this technique for predicting these two variables also. Then coming on to certain non-invasive measures. These non-invasive measures have been calibrated against the HVPG only. The liver stiffness, I think in most centers, it is being done in terms of fibroscan or transient elastography or shear wave elastography also. And this has been shown to have a good correlation with the HVPG measurements. But now the sphenic stiffness measurement is also one thing which is coming up. So both of these put together can actually help you assess the patient's progression of disease, as well as whether he or she is responding to conservative management or not. So that was about a bit of a evaluation of the patient, and about coming to the other aspects of pathophysiology, that is the third phase fluid. So now this third phase fluid is basically a function of the vascular tone. So there's a vascular vasoconstriction that occurs, as we have seen, because of the activation of renin-angiotensin system. And this actually cannot be treated directly by any IR procedure, but then it has to be taken care of, as I previously mentioned, that there are more than one stakeholders. So they have to be simultaneously taken care of so that you do not end up causing a complication. So it's because of the hyperresponsive vasoconstrictors that are circulating, as well as the overall increased vascular tone, and therefore this role of non-selective beta blockers. So as radiologists, as interventional radiologists, we should also try to understand that how to taper, how to calibrate, and how to manage the dose of non-selective beta blockers. Sodium retention is obviously again a function of the activated renin-angiotensin system. The cascade of sodium retention can be halted by conservative measurement, but then if we do a successful shunt creation, we can actually reverse this cascade and bring it back to normal. So we can, by conservative measurement, you can just halt the cascade, and by shunt creation, you can actually reverse the cascade and reset it back to the normal homeostasis and offer a better quality of life to the patient. And finally, there is one very interesting thing which has been increasingly researched in the recent past, is the role of sarcopenia in portal hypertension. And at our institute also, we are involved in some projects where we are evaluating the overall nutritional cost. So this is something which, when we were learning, this was not there. We never used to evaluate the patient for this. But now there is an increasing evidence that the overall nutritional status of the patient, the overall muscle bulk of the patient plays a very important role in the overall outcome after performing an IR procedure or a surgical procedure for portal hypertension. And the probable hypothesis which has been given is maybe muscle is an alternative site for ammonia detoxification. So if somebody who is having a liver which is compromised and the muscle which is also compromised, then there will be no other place where the ammonia can be detoxified from the blood, and the patient will end up having refractory encephalopathy. So this is one article in which they have shown that there is all the factors like serum albumin, hyponatremia, muscle depletion, and the muscle mass function. All these things in the patients who are having low values are having high chances of having overt and mild encephalopathy. So friends, I think this is just a basic concept which we were discussing about how to evaluate patients when we are planning a intervention for portal hypertension. But then with all this research and all this body of data which is already there, still a lot has to be done. A lot of research has to be done in each aspect. And this is from the recent guidelines, from a combination of the data which has been given from Baveno as well as the European guidelines, where they say that there are so many questions. TIPS has been a procedure which has been there. BRTO has been a procedure which has been there for years now. But still, small things like in the standard setting for TIPS, we do not know what should be the threshold INR and what should be the threshold platelet levels. Is there a threshold melt that should be used for selecting the patient for TIPS? In the setting of ascites or hepatic hydrothorax, what is the best approach for TIPS creation to balance the safety and efficacy? Now, these are very basic questions, come to think of it. But then we do not have any prospective data to suggest or to guide our decision-making process. And this has to be researched. In the case of varicose bleeding, what are the criteria for a preemptive TIPS? And what is the time for a rescue TIPS if it's a advanced child C patient? Similarly, what should be the surveillance protocol, and how to identify the target photosystemic gradient for intervention, and the novel indications. So in novel indications, they have mentioned many things, but Chiari syndrome has also been mentioned. I think for our country and especially for this institution, I think Chiari, TIPS in Chiari is not a novel indication per se. When we were residents, that then also we saw sir performing cases for even pediatric cases for Chiari syndrome TIPS. But then these small short case series and few case reports are there. No large prospective data is there to guide our decision making in such scenarios. So I think this is food for thought, which I will give to myself, to the audience, and to all the junior interventional radiologists who are intending to do some research in the field of portal hypertension. So I think with this, I come to the end of my talk. Thanks a lot. And again, I would express my gratitude to HOD Madam, Dr. Rajnikant, to the Institute Administration for having invited me over here. And my sincere gratitude to the Department of Radiology, SDPJ. Thank you.